First of all, I'd like to thank Adrian, Kerry and the entire team for the invitation to speak to you today on this important topic. And I'd also like to thank all the participants, and I look forward to learning as much from you as I do from you learning to me. Finally, I'd just like to thank my friend and colleague Joseph Solidio for his assistance in preparing the presentation and also his expert IT skills. So as you can tell from the topic, we're talking about staff safety, and for a long time it has been the elephant in the room, and that's true in all the working environments that I've worked with, in all the public hospitals I've worked in, and I look forward to learning from you how much that is also true in your professional practices. As I was saying, that the title for today's talk is The Elephant in the Room, where the elephant represents staff safety. For all too long, for a number of reasons I'll go into later in the presentation, staff have ignored their safety, and management, certainly in the hospital system, have also ignored the safety of their staff. And I believe that's been a retrospective step in patient care as well. The learning objectives for today, I would like that at the end of this presentation, that each of you will understand your personal risks and the risk to your practice of a sharps injury. I would like you all to understand the personal and practice costs of sharps injuries. I'll give you a very quick update on regulatory requirements, in particular in relation to scalpel safety. When we're looking at how to protect yourselves best from sharps injuries, I will give you an insight into the difference between passive and active safety. And finally, I'll give you a few very simple tips for you to use when picking the best safety device for your practice. And in case I forgot to mention, please feel free to interrupt me at any time with your questions. As an outline for the presentation, we're going to look at the consequences of a sharps injury, and the important thing here is that it's key for you to remember that a sharps injury not only affects you, it affects your work colleagues and it affects your family. It's very too easy to ignore that in the heat of the importance of your work. We'll look at the costs involved in sharps injuries. We'll look at the risk or likelihood of an injury. Then we'll go into some of the observations and research we did through the emergency department at the Princess Alexandra Hospital, and share with you our observations about why staff safety is neglected in the hospital system. And I hope to learn from you whether or not what we've observed in the hospital is the same or similar to the way your practices are run. We'll give you a current update on regulations and legislation, including the upgrade to the Australian standard, for which I was at a meeting in Sydney on Tuesday. I will answer the question how we can improve sharp safety, and finally I'll talk to you about whether or not sharp safety prevention is cost effective. And I'm sure you'll be able to guess what my answer to that question would be. Very quickly, a definition of a medical sharp, or a sharps injury, is a medical sharp, for example, a needle or a scalpel that injures a healthcare worker, resulting in the skin being broken or much worse. To start with, we'll look at the consequences of a sharps injury. And I'd like to break it down into a very easy classification. So sharps injuries fall into two broad groups. The first is an uncomplicated injury, and the second is a complicated injury. So an uncomplicated injury still results in expense and distress to the person who's injured. So if you suffer from a needle stick or a scalpel blade cut, it's psychologically distressing because of the risks. It's time consuming and expensive because you have to go and have the blood test. In the hospital, anybody who has a sharps injury comes down to the emergency department because we're open 24 hours a day. I suspect if you're in private practice, you would have to go and see your own general practitioner. Then there's the loss of your time and obviously that impacts directly on your patients. So if you have to go and see a local doctor to get your blood tests sorted, the patients who you should be looking after will miss out on your care. The second broad group is the complicated injuries, and again this can be broken into two subsets. The first one is the one that most people are worried about, and that's blood-borne infections with HIV, hepatitis B, hepatitis C, syphilis, herpes, and probably a dozen or more so infections that have been reported. With a scalpel blade, unlike the sharps injury from a needle or a hollow bore needle, the scalpel blade has the potential to sever a flexor tendon, artery or nerve, resulting in the need for microsurgery and up to 3 months of rehabilitation. For podiatrists, a bit like surgeons, your practice is based on your intellectual knowledge, your communication skills, but also on the dexterity with which you perform your procedures. And that requires your hands to be intact. In the international papers I often start with this slide and I ask the audience, what do these 4 people have in common? I won't ask you to answer that question now, but I will ask you to answer some questions later. And the simple answer is all 4 of these people were known to be infected with either HIV or hepatitis C or both. And my understanding is at least 3 of those 4 people have already passed away. And the point I'm making here is that sharps injuries can be fatal. I'll let you quickly read through this, but it's basically an account of an orthopedic surgeon who cut an ulnar nerve with a scalpel blade during a procedure. And as I mentioned before, just like a surgeon, if you have a significant injury affecting your hands, it affects your dexterity and it affects your ability to do your job completely. So hopefully you now understand what the consequences of an injury are. Let's look at the cost of these injuries. With an uncomplicated injury, it's estimated, or it's published, that the cost in Australian dollars ranges between $750 and $7,500. The reason there's such a big breadth in that range is because different studies include different factors when they're estimating the cost. For example, you've got the blood tests. There'll be blood tests to you as the new patient on the day at 6 weeks, 6 months, and in some cases at 12 months. Then the patient who you are looking after also needs to have blood tests collected. The larger figure also accounts for the time lost by you from your workplace and the potential impact on the patient. With the complicated injuries, I've already explained that if a flexor tendon, artery or nerve is severed, then you need microsurgery and 3 months of almost daily rehabilitation. And the estimates of that are up to $100,000. The surgery probably costs closer to $24,000. If you're very unfortunate and you get a blood-borne pathogen infection, the annual costs in Australian dollars are estimated to be $35,000 to almost $60,000. I assume that podiatrists, like all hospital staff, are immunised against hepatitis B. Therefore, our major risks are with hepatitis C or HIV. I've been through that already, and you're better aware of the anatomy of the hand than I am. So if I could summarise, when we talk about costs, we talk about the obvious costs and the hidden costs. I won't go through this slide in detail, but I'd rather make the point for you that if you were to pretend that you are either the financial manager of your practice or the financial manager in a hospital, it's easy for you to get the data to calculate what the cost will be of a new safety device or the cost of a new safety procedure. However, it is very difficult for you to actually determine your hospital's cost of an injury. And the reason for that is so many of these costs are scattered across the hospital. They're not tracked, and they're certainly not brought together and added up formally. It may be different in your practice, and if it is, I congratulate you on that. But certainly in the hospital system, nobody's measuring how much time you are off work. Nobody's measuring the ED costs for your practice. And then nobody's measuring as a separate issue the cost to employ staff to replace you if you are injured and unable to work. And again, if you have any questions, please don't hesitate to interrupt me. Alright, so we've looked at the consequences of a shaft injury. We've had a brief overview of the cost of an injury. Let's look at the risk or the likelihood of someone having an injury. The simple statistics are that in Australia it's reported that there are 18,000 shafts injuries every year. When you realise that 70% of all shafts injuries go unreported, what we're really looking at is an injury frequency rate of probably close to 60,000 annually. And I'd ask you, what workplace would accept that sort of an injury rate? In fact, in America there's an organisation called the Public Citizen, and it published a report about 5 years ago in which it described hospitals as high hazard areas. And I think reports like that have started to facilitate clinical staff like you and I in understanding the risk of our injuries and the fact that we shouldn't be exposed to these injuries and we need to be protected from them. When it comes to scalpel blade injuries, the two of the big figures are that it's the second most common injury in an operating room, and it also accounts for 8%, which is a very big number across the entire hospital. To put things into perspective, most of the work on prevention has been related to preventing needle stick injuries, and the reason for that is valid. The number of syringes used in a hospital or in clinical practice is enormous, and as a result most injuries occur as a result of injuries from needle stick. But to put things into perspective, I'd like to share with you some data from an article published about 20 years ago. So if we look at the figure on the right, this study by Eisenstein looked at the number of injuries and determined the incidence rate based on the number of purchases. So in his study he reported that if you were to buy 100,000 syringes, 3.2 would be involved in an injury. However, when we looked at the scalpel blade injury rate, in his paper he said there were 662 scalpel blade injuries for every 100,000 scalpel blades. However, we believe there's some sort of miscalculation in that article, and we're about to publish the results from the PA hospital. In 3 consecutive years there was an average of 12.4 to 12.6 scalpel blade injuries. So when you look at those two figures in the slide before, what it's really telling us is, as would be expected, scalpel blades are designed to cut, so they cause a lot of injuries. That scalpel blade usage tends to be a little bit limited in hospitals to operating theatres and where the podiatrists are working, and therefore we now have the ability to reduce this significant number of injuries by focusing our attention in discrete areas of the hospital, or in your case in your practices. What we're looking at here is the risk of seroconversion. So if you have a shafts injury, in particular from a hollow bore needle, from a patient who is HIV positive, the risk of you seroconverting and getting a HIV infection yourself is 1 in 300, which is pretty high. Can anybody tell me what they think the risk of transmission is from either hepatitis B or hepatitis C? While I'm waiting for you to type in your answers, I'll share with you, probably about 18 months ago, I asked a group of interns, so first year doctors, this question, and their guesses astounded me. They all thought it would be 1 in 10,000 or 1 in 100,000. And they were quite surprised when they learnt that for HIV it was 1 in 300. For hepatitis B it's 1 in 3, and that's a little bit like playing Russian roulette. The difference here obviously is that the risk of you getting hepatitis B should be very, very small, because hopefully you are all immunised and hopefully all of your immunisations are up to date. And the risk of hepatitis C is also quite significant. It's 1 in 30. Until recently, there was no treatment for hepatitis C, and there's still no vaccine to prevent infection with hepatitis C. So in the old days, if you got a sharps injury and you contracted hepatitis C, there was a significant risk that you would go on and develop cirrhosis of the liver, and in a smaller percentage of cases you would go on and had a risk of going on to develop hepatocellular carcinoma. Fortunately, in the last few years, a number of drugs have been developed that can in fact cure hepatitis C. The problem is that the cost of that cure is between $80,000 and $100,000. So the big debate going on in healthcare now is which patients with hepatitis C should be treated first. This is one slide that I will, or a series of slides that I will need to get your feedback. So we know, and it's been published for 20 or 30 years, and I don't think the statistics have changed, that 70% of all sharps injuries go unreported. We believe that there are 3 important reasons for this. The first one is denial. So as part of my physician's training, I won't say when, but back in the early 1990s, I was the medical registrar in the Wattleborough unit at the Royal Brisbane Hospital, where all the patients with HIV were treated. Back in those days, the seroconversion was a little bit unclear, but it took approximately 10 years until you developed your HIV defining illness, and almost to the day, 4 years later, you would die. When I was working there was one of the nurses who, for her own reasons, refused to wear gloves because she didn't want her patients to feel as though they were being treated differently. One day she had the inevitable needle stick injury. I remember, because I had to look after her, she went white as a ghost, and she was off work for 3 days purely and simply because of the distress that injury had caused her. Fortunately, she didn't contract any illnesses, but it was a very salient reminder to all the staff that this is a real risk and that we do need to look after our own safety. The second reason, and I suspect there's a fair bit of this in podiatrists as well, is that if you're in the healthcare profession, if you take a risk for your patient, it adds to your personality. If you take a risk for your patient, you're a better person. If you take a really big risk for your patient, you're an even better person. For example, in the old days, if someone said the doctor on night shifts is called in sick, and you said, yes, I'll do the night shift, there was that, it added to the values that got you into the profession in the first place. So in this slide, what we see is the man on the right running over hot coals barefoot to rescue a child who's crying, whereas the woman on the left realises that it's not an urgent situation, puts shoes on so she protects herself, and then she goes over and can console the crying child. The third reason is that I believe there's a lot of self-blame. So I'd like to go off script here a little bit and share a story with you. So, and I apologise for the naming a couple of products, but my friend and colleague Dr. Neville Henry, who invented some of the safety products that we now commercialise, is an interesting man. He was awarded an AM for all the work he'd done for the International Red Cross. When he invented the sterile scalpel blade remover, I took that and another invention by a man called Glenn Riverstone, who at the time was a nurse in the Rockhampton Hospital, and he'd invented an ampule opener. So I basically showed 2 products, one a sterile scalpel blade remover and the other an ampule opener, to nurses and a few doctors in 4 or 5 different countries. And much to my surprise, the response to the sterile scalpel blade remover was, oh, that's a very clever product, it works very well. But when they saw the ampule opener, their physiology changed. They stood up straight, their eyes lit up, and they were actually putting their hands in their pocket to buy one at the same time. I can remember that my initial reaction to observing this was, I was taken back. Originally I thought they were saying that someone else's baby was better looking than our baby, but I eventually realised that my concern was that I was observing highly intelligent, well-educated nursing staff who were basically saying that they were more scared of an ampule cut than a cut with a used scalpel blade. And that makes no sense at all. When we thought about this a little bit longer, what we realised was that if I, as a nurse, cut myself opening a glass ampule, it's the ampule's fault. All of my friends and colleagues will have suffered similar injuries, so I could show them the little cut on my thumb or finger and they would console me and tell me what a terrible ampule it was. However, if I now change my role and I pretend that I'm a scrub nurse in an operating theatre and I cut myself taking a scalpel blade off with my fingers or a pair of artery forceps, I'm embarrassed. It's as if I have failed to do my job correctly. Because I'm embarrassed, I'm not going to report it. And that, I think, is a big contributor to the reason why 70% of all scalpel injuries go unreported. The consequence of that is even worse. It means that if I'm not going to report it, I'm not actually going to go and look for a safer alternative to reduce that risk to me. And in the emergency department, I can remember two of our registrars coming up to me probably 2 weeks apart. They both suffered Sharps injuries, and the first one said to me, while looking down at the floor and being quite gloomy, "Oh, it was my fault. I was rushed." Which makes no sense, because in his mind, he would never have another Sharps injury because he would never be rushed again. And in an emergency department, that's impossible. And the second registrar said to me that it was her fault because she had not been concentrating. And again, you can't concentrate all the time. So what we need to do is look at safer devices. Now, I'm going to go off script again here, just very briefly. As a result of my observations, I had an article published in the British Medical Journal stating that you couldn't develop a good culture of patient safety if you didn't first develop a culture of staff safety. And the main thrust of this hypothesis was that back in 2000, the Institute of Medicine published a report that you may or may not remember that stated there were 100,000 preventable deaths in American hospitals every year. Like most doctors, I threw my hands in the air and said that that's nonsense. But over time, it has become very clear that hospitals are dangerous places. One of the main thrusts to try and reduce the number of preventable deaths was to create and implement a no-blame culture for patient safety. So the theory is that if I make a mistake, whether the patient's harmed or not, and I know you as my boss are going to yell at me if I tell you I've made a mistake, then I'm not going to tell you. However, if we work in an atmosphere where there's a no-blame culture, I'll tell my boss that I made a mistake. My boss might ask a couple of you and myself and work out what happened, and is there a way that we can prevent me and my colleagues from making the same mistake in the future. So the thrust of our paper was that it's hard to reconcile telling a staff member that you should operate in a no-blame culture for patient safety, but enable you and sometimes facilitate you operating in a self-blame or a blameworthy culture for your own safety. So our belief for a long time has been there should be one safe culture for everybody. So I hope that's made sense. I'd like to move on very quickly and show you the current regulations and legislation in relation to sharp safety. So Queensland Health has some recommendations, but again I'll go off slide just very briefly. Bill Clinton in 2000 signed into law the Safe Needle Stick Act in America, I think back in around 2000. In 2010, the European Union also passed a directive, and each of the member countries of Europe had to pass their own national legislation by 2014. Unfortunately, in Australia, there is no legislation on sharps injuries. However, Australia, unlike the other countries, does have a standard in relation to scalpel safety. And it looks pretty simple, really, doesn't it? You shouldn't use fingers to remove a used scalpel blade. You shouldn't use artery forceps or other instruments not designed to do it. and you shouldn't use a resheathing method. And so I'd like you just to have a quiet think about personally whether or not your practices are safe and whether or not the practices in your clinic are safe. So getting down, now that we've addressed the problem on a number of levels, I'd like to talk to you about how we can improve shaft safety. And I've broken it down into 3 simple steps. The first one is that we all have to acknowledge that there's an elephant in the room. And I go further and say, I think that you need to acknowledge that your personal safety is important. It's a basic human right that when you're at work, you should be safe. The next thing I'd like you to acknowledge is that an injury to you has an impact on a lot of people, not least of all your family and your patients. And what I'm trying to do here is to politely give you permission to say that your safety is important, because logically you already know that, but certainly in clinical practice we tend to put patient safety above our own safety. And a study that we did at the PA hospital a long time ago, which is still the biggest publication of its kind in the world, showed there were 137 injuries, and roughly 50% of them, if we have a look at the blue colour in the middle, occurred in use, and they are potentially preventable, or potentially not preventable at this stage. But it means the other injuries, almost 48% of injuries, are preventable. And in broad terms, you have 2 choices. You can use a safety scalpel, or you can use a single-handed blade remover and a passing tray. And there are studies that show that, or indicate that using a single-handed blade remover and a hands-free passing tray are up to 4 or 5 times safer than a safety scalpel. And I will explain that to you now. So the second step is picking the appropriate products. So again, I'll go off script here a little bit and tell you about a lady called Karen Daly, who I've met a couple of times and who I co-presented on staff safety at the National American Operating Room Nurses Conference a few years ago. So Karen Daly's story goes back. She was a nurse in one of the Boston hospitals, working in the emergency department on, I can't remember, Saturday or Sunday. She was working in triage. At the end of a 12-hour shift, one of her colleagues had failed to take blood from a patient, so she stepped in to help and unfortunately got a needle stick. All she wanted to do was go home because she'd had a bad day, and this needle stick injury was just topped it off. However, her friend, who was very embarrassed by the fact that her colleague had had a sharps injury helping her out, insisted that Karen report the injury, which she did, and to cut a long story short, she developed both HIV and hepatitis C. Fortunately, she's well and continuing to live a very good life. After 12 or 18 months, when she got over the psychological trauma of the injury and the illnesses and the complications of the drugs that she had to take, she started to go out of her way and work to improve safety for all nurses and everybody working in the hospital. And she is one of the key players who actually facilitated the American Senate in passing Bill Clinton's law on the Safer Needles Act. She told me that during the process, that almost as a concession to industry, there was a little bit of watering down of the original legislation. And in the legislation they inserted the term safety engineered device. And that meant that the safety devices had to be part of the original device. And I can find nowhere in legislation from any industry where a safety feature being part of the original device offers any safety in its own right. So if you could please have a look at these 2 safety devices. The one on the left is the best. It's what we refer to as a passive safety or an automatic safety device, and it's the spring-loaded syringe. On the right-hand side, this is one of the first safety syringes they produced. If you can see the blue bit of plastic on the right-hand side, that was basically for the user to push that over the needle, which you can tell very easily is a very unsafe practice. It's basically breaking all the laws by universal precautions and it is virtually a recapping type exercise. So that device is called an active safety device because it needs to be manually operated. So I think when you look at these two, you can tell that the safety device on the left, which is passive or automatic, confers a lot more safety than the device on the right. And more recently, there are a number of publications actually confirming the logic of this picture, and they are showing that there's a rising number of injuries from safety devices, and most of those injuries occur as a result of somebody using an active rather than a passive safety device. So if I could go back and say, my tips for you to be as safe as possible, first of all, you have to recognise there is a risk to you and your colleagues, and the second one is my advice would be to pick the best product you can. And to summarise, a passive safety device, which is an automatic safety device, is much safer than the alternative manually operated device, and there are publications now that confirm this. I'll go back one. So when it comes to scalpel blades, which are obviously very important to podiatrists, we coined the term scalpel safety as an overarching term that covered single-handed blade removers and safety scalpels. And the reason we did that, we believe you as the clinician need to select what is the most appropriate device for the situation or for the procedure that you're conducting. The Australian College of Surgeons did a large literature review 5 or 6 years ago on safety devices and found there is actually no evidence that safety scalpels have ever prevent injuries. And more recent publications I referred to a moment ago are showing that that type of active safety device is involved in more and more injuries each year. The third part is very interesting. So we've taken this from the Podiatry Board, where they refer to a self-audit tool. So time permitting, I'm going to go off slide again and share with you a story about seatbelts. So as an emergency physician, probably 10 or 15 years ago, I was in Minneapolis and I was talking to a young emergency physician there who quite proudly told me as part of his non-clinical duties, he had been involved in his state becoming the third state in America to introduce seatbelt legislation. Unfortunately, because there was no penalty, everybody ignored seatbelt legislation. So seatbelts in Australia have saved an enormous number of lives and reduced road trauma morbidity enormously. In Australia, I can remember when seatbelt legislation was introduced, and it came with a penalty. So if you were found not wearing a seatbelt, the policeman or policewoman could issue you a significant financial penalty and take from memory 3 points off your licence. So not surprisingly, seatbelt adoption in Australia was very quick. To put it into perspective, back in the 1960s, they say that you sold a car based on the results of the racing over the weekend. It was thought that safety features were unmanly and in fact did not promote the sale of your cars. With ABS brakes, with seatbelts, it's obvious now that the safety features of a car are a very important sales tool. And my belief is that in healthcare, like in the motor vehicle area, that as people adopt more and more safety tools, it will become the norm. So instead of people saying you should be using a safety tool, people will be going, where is my safety tool? Lastly, I'll just answer the question that may or may not be relevant to you, but it is certainly relevant in large hospitals about the cost. And can we afford a sharp safety device? The benefits of using a safety device to prevent sharps injury is basically in preventing all the costs of an injury. And we've been through these earlier with that picture of the iceberg. So if you can prevent an injury, it means you don't have to go and have lots of blood tests. It means your patient doesn't have to have extra blood tests. It means that your patient doesn't have their procedure delayed or cancelled, and it means that you're not injured and you don't have to take time off work. It means that your practice isn't going to have an increase in their workers' compensation premium. It means that your insurance premiums aren't going to go up. From a social cost, it means that people in your practice aren't going to be missing. It means that you're not going to have to employ other staff to come and cover the costs, to come and cover the procedures that you would normally do yourself. And finally, it means that you as an important staff member don't suffer the consequences of that injury, and that your family are not penalised watching you suffer through the awful medications to treat some of these illnesses, or putting up with you being off work and on a reduced salary. So hopefully I've convinced you that preventing injuries is important, both on a cost basis and on a personal basis, and on a basis that it affects your patients as well. And that if you are going to use a safety device, you should use a good one, and that would be a passive safety device. I'd like to finish by sharing with you something very important about Qlicksmart. As I alluded before, my friend and colleague Dr. Neville Henry invented the world's first single-handed scalpel blade remover. He did so in response to one of the nurses who was complaining about having to use a pair of old artery forceps to remove the scalpels at the end of a procedure that Neville had done. And he literally went home that weekend and put together something in his garage. But at Qlicksmart, as you can tell, staff safety is a big passion of mine. So we also produce educational material, and we do a lot of lobbying. So we're involved in the first Australian standard that I showed you a summary of earlier. And on Tuesday of this week, I was in Sydney at a standards meeting where we plan to update the Australian standard. And then there is a proposal for that Australian standard to be made an international one. We also work with other clinicians who invent things to help them get their products commercialised. And if I could finish with the other thing we do is lobby for change. So we managed to have the House of Representatives in the state of Michigan, in the States, and the Senate pass resolutions stating that their hospitals were to implement a staff safety score audit to ensure that they were being compliant with legislation and OSHA guidelines. Unfortunately, this safety score audit never made it into legislation because it was blocked by a powerful self-interest group. But anyway, we did try. So when I first started out on this campaign 15-20 years ago, the staff safety circle was very small. I think today staff safety is being considered to be more and more important, but it still is very much a second player to patient safety. What we're hoping and what we're working towards is tomorrow's thinking, where there will be one culture of safety for everybody, for staff and patients alike. And I'd like to finish before I answer the comment that's just come through with a quote. If you think safety is expensive, try having an accident. So thank you very much for your attention.